Our next speaker is Oliver Sartor from Tulane Medical School.
Thank you, Bruce. It's a real pleasure to be here. And you've got a terrific lineup, and what a sort of momentous occasion it's been. It's really stretching over the past 13 months when prostate cancer has really become a changed disease because of the progress. It's rather extraordinary and certainly unprecedented in this field. We look at the taxanes really today as sort of pivotal agents in prostate cancer. And when we look at this disease, it was the first survival benefit that taxanes were really able to confer. The history of regulatory approvals I'd like to review here. And as you can see, it goes all the way back to 1981. But then we move on into a variety of palliative agents, strontium mitoxantrone, samarium, zoledronic acid, and finally in 2004, the first agent to be able to prolong survival were docetaxel and prednisone combination. And since then, with sickle cell T in 2010 for the FDA approval, cabazitaxel in 2010 for the prolonged survival, the denosumab, and now the abiraterone just 2 days ago. The prolonged survival is what has really been changing in this disease. But I'd like to return just for a moment to docetaxel because for many years this was the only agent that had a survival benefit. And I'm sure you're aware there were two large trials, Taxatate-Resistant industry-sponsored, SWOG 9916 through the cooperative groups. Both of these use mitoxantrone as a control group because that was considered to be the palliative standard of care, and docetaxel in either a 3-week regimen or in the case of Taxatate-Resistant also a weekly regimen. And both of these trials concluded that there was an improvement in the overall survival. And this was the SWOG 9916 study from the New England Journal. Here's the Taxatate-Resistant, also from the same issue, the New England Journal, showing a modest benefit, but an important benefit because it was the first time that there was a survival advantage shown in this very difficult to treat disease. Now, as a consequence of these survival advantages noted in 2004, there were actually sort of 3 spaces defined, if you will, for metastatic CRPC. First of all, we had this sort of nebulous pre-docetaxel space. And why do I say it's nebulous? Because actually the docetaxel indication would extend to anyone, whether or not it be symptomatic or asymptomatic. But in the sort of parlance of our field, the pre-docetaxel space began to be that area where there were evidence of metastatic disease, but really not a lot of symptoms. And many oncologists were somewhat reluctant to give chemotherapy within these asymptomatic patients. So sickle cell T, which was the autologous immunotherapy, began to target this space, and now it is FDA approved. Second space was that in combination with docetaxel. This has really been such an attractive opportunity to so many companies because they look at the docetaxel survival curves and say, we can do better if we just add in agent X. Well, X and Y and Z and A and B and C and D have now all failed. The most recent failure in this sort of space is atrasentan. And that follows the ZD454 and these endothelin antagonists, but it also with vaccines and with vitamin D and a variety of other compounds. So the bottom line is improving on docetaxel by adding your agent to it has been extremely difficult. And now the post-docetaxel space. As soon as docetaxel was approved, it was immediately apparent that there was a post-docetaxel space. We actually went after that in the Satrasplatin-SPARK trial and failed, and came back with a cabazitaxel trial and succeeded. And now abiraterone has succeeded in this space, and the label indicates, the one that was just approved 2 days ago, that abiraterone is approved for the castrate-resistant metastatic patient who has had prior exposure to docetaxel. So now these spaces are perhaps becoming a little bit more defined. Now, when we look at sort of the validated target for taxanes, we're really talking about microtubules. And these are cylinders formed with alpha tubulin, beta tubulin, And these are critical components not only in cell division, but also in intracellular transport and the development and maintenance of cell shape. So the taxanes hit the microtubule. That is their validated target. But there's actually potentially more. This is data from a recent study published from Natasha Cipriani's laboratory, in which she demonstrates that tubulin-targeted chemotherapy actually impairs the localization of androgen receptor to the nucleus, and it actually does it quite efficiently. So we don't ordinarily think about taxanes as being androgen axis targeted therapy, but in truth, that could be the case. And I think as we look at these newer agents, it'll be quite interesting to see how they have potential interactions. And we just heard on the abiraterone discussions about the microenvironment, which I think is absolutely critical. But this is another opportunity to potentially alter that microenvironment. And as we move forward, I think that these studies will need to be explored. So as I asked a little bit earlier, as soon as we have an effective agent, it's incumbent upon us as a field to understand the mechanisms of resistance. How do taxanes fail to work? And I think it's probably multifactorial. There have been microtubular mutations that have been described. There certainly is the MDR efflux pump that has been described, and other poorly defined mechanisms. But when we come back to the taxanes, and we realized that docetaxel was actually a quite active agent, at that point, the scientists at Rompelonc, and let's go way back in the Sanofi-Aventis sort of lineage, we go back before Aventis, and we go back to Rompelonc-Rohr, and then we go back to the Rompelonc chemist. They realized that an active agent presented an opportunity as well as a challenge. And what they decided to do was to look at ways to overcome docetaxel resistance. And their objectives were to look at a compound that had the same potency as docetaxel against sensitive tumor models, but they wanted it to be more potent than docetaxel against tumor models' resistance to chemotherapy, including docetaxel. And they started off by screening about 450 derivatives. Their medicinal chemist got busy and put on all sorts of derivatives. They looked first in activity on tubulin polymerization as initial screen, came back in vitro against tumor cell lines that were sensitive, then came back in vitro activity in docetaxel-resistant cell lines, and then they developed some tumor models that were specifically resistant to docetaxel and measured this in vivo. And cabazitaxel was the agent that came out of these 450 molecules and was selected for further development based on the interesting preclinical activities. Now, it's interesting to me that the actual structural alteration is minimal. This is the docetaxel parent, this is cabazitaxel, and you end up with a couple of methoxy groups here and here. That's the only change, but that change turns out to be a critical change. Now, moving into the clinic, there were 3 phase 1 studies, and this is a little bit confusing. First of all, if you start looking at cabazitaxel, you realize quickly that there's virtually no literature. And then you realize that it's existed under a variety of different names, XRP 6258 and Taxane 258. So you go back in time and you have trouble understanding the lineage of this compound. Furthermore, a lot of the early studies were not published. There's Sanofi-Aventis data on file. So it turns out there were 3 phase 1 studies, dosing at 10 to 30 milligrams per meter squared IV Q3 weeks, 1.5 to 12 milligrams per meter squared Q week times 4, coming up, depending on which trial you cited, for recommendations of dosing between 20 and 25 milligrams per meter squared IV Q3 weeks are the weekly regimen. Now this weekly regimen ended up with a little more diarrhea, and the Q3 week is the one that kind of moved forward into the clinic. Now, it was interesting that within the phase 1 studies that they noted anti-tumor activity in docetaxel-resistant metastatic prostate cancer. And that sort of impetus moved straight from phase 1 into phase 3. So if you go look for the phase 2 trial of cabazitaxel in prostate, you will not find it. So the phase 3 trial was designed, a large trial, 146 sites, 26 countries, very global, and the hormone-resistant criteria was used because that was the nomenclature at the time. That's castrate-resistant today. Metastatic prostate cancer, previously treated with a taxotere, and it was Sanofi, excuse me for not saying docetaxel, but that's the way it was originally designed, and containing regimens. So the bottom line is you randomize 1-to-1 between mitoxantrone and cabazitaxel, both other arms containing prednisone. And people have asked, well, why did you use mitoxantrone here? And I think it's a very legitimate question. But when we look at the way the drugs have developed at the time that this trial was started, there was nothing approved in the space. And abiraterone, for instance, used prednisone alone as a control group. The NDV-3100 has used placebo as a control group. And here we thought that mitoxantrone, being an intravenous therapy that had some activity, would be an accepted alternative. And that's what we went forth with, the mitoxantrone Q3 weeks as a control group, with everybody receiving the low-dose prednisone, 5 milligrams PLBID. So there were 755 patients, targeted maximum treatment duration of 10 cycles. Why 10 cycles? Because of the mitoxantrone. You start running into cardiotoxicity with higher doses of mitoxantrone, and a planned analysis at 511 events, with the overall survival being the primary endpoint. Eligibility criteria, obviously metastatic castrate-resistant disease. If you had measurable disease, you could not simply have a rising PSA. You had to progress by RECIST criteria. If you were non-measurable, then a PSA progression or appearance of a new lesion would suffice. You had to be pre-treated with at least 225 milligrams per meter squared, but that was actually a protocol amendment. There was no minimum at the time the trial was actually started. No prior treatment with mitoxantrone, ECOG performance status 0 to 2, and good organ function. In terms of the patient characteristics, we can see something that we're fairly familiar with now. Median age of the patients, kind of upper 60s. Most of the patients, in fact, did have a good performance status, ECOG 0 to 1. Median PSA is 127, 143. Measurable disease, a little bit higher, and I think this was because of the advanced nature of the patients as well as the RECIST criteria for progression. Measurable disease in the majority of patients, and visceral disease in about 25% of the patients. So these are advanced patients, much as seen in the abiraterone trial. There's a lot of similarity if you look at them head to head. Now, in terms of the protocol treatment, it actually allowed more than just docetaxel. And in fact, a lot of these patients did not just have one regimen of prior chemo, they had multiple regimens. So about 30% of the patients had 2 or more regimens of chemotherapy before entering into this particular trial. The median dose of docetaxel was about 7 cycles, 529 or 576 milligrams per meter squared, and the median time from the last docetaxel progression was short, less than 1 month. Primary endpoint, overall survival, unequivocally positive in the intent to treat analysis. Median survival 12.7 versus 15.1, but I think the actual median is a little bit deceptive here. You end up with a continued separation of the curves. Hazard ratio excellent, 0.7, good p-value, and this really served as the basis for the FDA approval that occurred last summer. When we look at the various subgroups, they're virtually all positive. I think there are a couple that bear particular notation, and that might be here in North America. The hazard ratio is actually 0.59, really quite good. All the others really heading in the right direction, except for other countries. So this very global trial, actually, when you look at the countries outside of Europe and North America, could be a small subset, but the hazard ratio in those patients were actually 1.0. Now, the subgroup analysis, when we look at the total taxotere dosing, I think is also quite interesting. The patients who had the very best hazard ratio of all the subsets were those patients who received 900 milligrams per meter squared of prior taxane, and the hazard ratio here was 0.49. I think this is probably the patient who is taxane sensitive and then becomes resistant, and now the cabazitaxel offers a particular advantage. There was also a lot of question about whether or not is this just another taxane, and I think that this helps to answer that no, because the patients who progressed during their last docetaxel treatment had a hazard ratio of 0.67. And whether or not it was more than 6 months later or during, these are the patients that never would be predicted to have a response to additional taxane unless it were a different taxane. And I think that's an important number to look at. We look at the secondary endpoints. They're all positive except for the pain. Tumor response rate was slightly better. This is very similar to TAX-327. It's statistically significant but not huge. Only 14.4% of patients will actually have tumor shrinkage as measured by RECIST criteria. PSA response rate's about 39%, but remember this does not alter the antigen axis. This is probably real tumor shrinkage. Time to PSA progression, 3.1 versus 6.4 months, and that's also statistically significant. Pain was not improved in this study, a little bit of a disappointment. It may have been due to the way things were measured. It may have been due to the international nature of the trial, but those are the results. The hazard ratio was 0.91. Now, what about adverse events? Important to understand what those might be. Febrile neutropenia for cabazitaxel was 7.5%, which is pretty high. Diarrhea grade 3 or worse, 6.2%. The rest are really fairly reasonable, and notable by its absence is the lack of neuropathy, and that was really quite low. There was very little neuropathy actually observed in the trial. Now, one of the things that you have to realize when you're looking at a patient with advanced stage disease is that the amount of neutropenia is going to be greater than if you were looking at patients who had less prior treatment. Let's look at this in an interesting way. We had the mitoxantrone given in the same dose and schedule in the cabazitaxel trial as it was given in TAX-327. The differences were second-line therapy versus first-line. And we look at the neutropenia for mitoxantrone prednisone, grade 3 or worse, and it was 58%. If we go back to the TAX-327, it was 22% for the same drug at the same dose. And I think that there are differences in the patient population, but there's also another important difference, and that is the CBCs were actually monitored weekly here, and there could be an ascertainment bias over detecting the grade 3 neutropenia at a higher rate. Now, fatal events. 4.9% of the patients on cabazitaxel, 18 of the total patients, had deaths due to adverse events. When we look at this geographically, it also turned out to be quite interesting. Due to adverse events in North America, 235 patients treated on the trial, so that would be about 50-50 in each arm because it was a 1-to-1 randomization. There was only one death in North America, 0.9%. And I suspect that our oncologists are very practiced in terms of handling neutropenia, and that may be part of the issue in these results. Now, the FDA package insert is quite interesting on cabazitaxel because it actually recommends primary prophylaxis with G-CSF, and this was not part of the trial. There's actually a first cycle growth factor exclusion in the cabazitaxel trial, but the FDA said that G-CSF should be considered for patients age greater than 65, poor performance status, prior febrile neutropenia, poor nutritional status, or other serious comorbidities. So my conclusion is that it's an effective drug fulfilling an unmet need with a safety profile that demands meticulous attention to the management of neutropenia and diarrhea. Now, let's go back for a moment to those phase 1 trials, and I mentioned that there were actually 2 doses recommended depending on which trial you might like to cite, either 20 or 25 milligrams per meter squared. So what has happened is that the FDA has now suggested that there be a post-docetaxel trial looking at these two doses, 20 versus 25 milligrams per meter squared, and asking the simple question, do you retain the activity and perhaps have a little less toxicity with the lower dosage? The other question, and you can immediately see it coming, is that if this agent is effective in the post-docetaxel setting, how would it compare head-to-head with docetaxel? And that trial is going to go forth as well, and that's called the First Standard trial, and it'll be starting very, very soon. Accrual will be starting in the next month or so. So today we have a huge variety of options for castrate-resistant prostate cancer. I had to modify my slide in order to put the abiraterone in at the last minute because it was actually less than 48 hours ago that we had the approval. We have a variety of palliative therapies with radioisotopes, with the bone-targeted agents. Now we have the new chemotherapy agents. We have the immune therapies. And I think one of the real challenges is how do we integrate these therapies? How do we combine them? How do we sequence them for optimal patient benefit? The thing that I feel confident and I really do feel good about is that I know that our patients have more options today than ever before, and I think that they will be the beneficiaries of the progress that you've seen in these slides. Thank you very much.
Thanks, Oliver. So let's have some questions. Matt?
I think you indicated the key point, which is we now have 2 approved therapies in the post-docetaxel space. So I'll ask you the burning question in the field, which is abiraterone or cabazitaxel in those patients, and how would you choose between those 2?
The answer is simple, both. And the question is, how do we sequence them? You know, I think the toxicity profile of abiraterone is just outstanding. I mean, when you look at the ability of this oral agent to induce responses with toxicities that include edema and potential problems with potassium and all, but they're really quite minimal. I think that patients will get abiraterone quickly. It's a personal opinion, post-docetaxel, but inevitably they will progress. And unfortunately, we know that the time to progression is not as long as we would really like it to be. And there we have cabazitaxel, perhaps given to a patient who might even have a better performance status and a little better tolerability of chemotherapy post-docetaxel, post-abiraterone, if you will, because now the patient may go on to another agent and it's almost another variant of intermittent chemotherapy where they get a nice rest before they go on to the next thing. So the bottom line is, if it's not confusing me to say, I think that many patients will receive both drugs, but it wouldn't surprise me if abiraterone is the first one used post-docetaxel.
So, Oliver, for the patient who has a very good performance status, is there going to be a trial of the combination of the 2 drugs?
Well, you know, it's very interesting, and there's been discussion, but no commitment at this time. It's very reasonable, in my opinion, to think that abiraterone will move up much earlier in the hierarchy of treatment. And as a consequence of Cougar 302, which many of us believe will be positive, abiraterone moves up front, and cabazitaxel is going to remain in the post-docetaxel space until there's clear evidence. So if that's the case, the combination trials may not be the ones that we want to do right now.
Marty Sanda from Beth Israel Deaconess Medical Center, Urology. So I have 2 questions, and they both relate to the issue of side effects. And ultimately now, as the landscape of options is growing in androgen-resistant disease, I think it's clear that side effect profiles are going to be a key determinant of order of treatment, type of treatment. So the first relates to the differences that you saw in terms of the toxicity in the European as compared to the North America treated patients. And I wonder whether there were other factors that looked significant in terms of predictors for that toxicity. Specifically, for example, age, type of prior pretreatment time between the most recent preceding treatment course, for example, and other factors. So that's my first question. And then my second question is, as we look at these side effect as we look at these, the need to discern side effects more, both with greater sensitivity and with a better quantitative analysis. I think we really need to consider the patient-reported perspective. Mm-hmm. And so the second part of my question is not just to you, but to all of those discussants of the systemic treatments. What about the patient-reported perspective mm-hmm. of the side effects? Is there data that goes beyond the now somewhat limited physician-reported perspective? And if not, how do you foresee that that might be incorporated in future trials?
Great questions. With regard to the patient-reported outcomes, which I think are very important, it's quite interesting that the FDA has chosen from a regulatory perspective to minimize that reporting, believing that unless you can match things and blind things very, very well, that they may not be valid. Now, I agree with you that the patient-reported outcomes are the most important. There are two things we really seek. We want patients to live longer and to live better, and hopefully they'll live both longer and better. That stated, we don't have the data today on patient-reported outcomes, and I think that that would be a good opportunity within like a taxane, cabazitaxel, docetaxel sort of arrangement. But we don't have the data today. Great question. That analysis is ongoing. There are some age-related things. There are, in my opinion, some geography-related issues, and there's also some prior toxicity-related issues. You know, patients who had prior febrile neutropenia are more prone to subsequent neutropenia. Patients who come into the trial with lower neutrophil counts are going to be more prone to complications. And so there's a variety of other biases that we need to be able to analyze and put forth into the public domain. Right now, this has not been done outside of the context of the FDA. But I will say that the FDA was quite thorough, and that if you read the label, there's a lot of detail about toxicity and conditions. So great questions.